Hi, I'm Karma Matti-Jackson, CEO of Matti Consulting. Thank you for joining me today for this segment of a four-part series entitled A Critical Hour for Long-Term Care. You know, chances are that all of us have heard something in the headlines recently about skilled nursing facilities, assisted living, COVID-19 and long-term care, or maybe something to do with staffing shortages in long-term care. The purpose of these briefings is to provide some data to sort of wrap around those headlines and to give us all some additional information to consider as we make our opinions and decisions about long-term care. This presentation deals with the COVID-19 pandemic and its impacts on long-term care here in Washington State. Unlike the other presentations in this series, data for COVID-19 is in its infant stages and the criteria for collection changes frequently. So I have included some data from field studies and surveys as well. There is no doubt in my mind that long-term care is the front lines for the COVID-19 pandemic. This is an elderly, vulnerable population with many multiple chronic conditions, health conditions, living in congregate settings. And what we find are providers and staff that are struggling with inconsistent directions and inconsistent information, trying to make sure that not only the residents are protected, but staff as well. There's no doubt that long-term care has been hit especially hard with COVID-19 pandemic. Since March of 2020, there's been over 1,177 distinct buildings that have had COVID-19 among staff or residents. And when we take a look here at the DSHS data, it shows the trajectory of the number of buildings that have COVID-19 active cases. As of January 15th, we're down to about 567, which is good. We're moving in the right direction. But overall, as part of the state spectrum, 6% of all cases have been in long-term care, whereas 51% of deaths have been in long-term care. One of the things I think is important to clear up is the number 51% of deaths in long-term care is often attributed solely to skilled nursing facilities, and that's just not the case. In fact, we know that the pandemic began in a skilled nursing facility here in Washington State, but we also know that the state and the providers have taken great measures to protect residents and staff, and those numbers have come down significantly from where we started. What we're looking at on this slide is we're looking at data that tells us on a state-by-state basis the total number of deaths in each state and what percentage of that is related to skilled nursing facilities. And we see here in Washington State that 24% of the deaths are related to skilled nursing facilities. To me, nothing says frontlines more than talking about where the battlefields are. 97% of skilled nursing facilities in Washington State have had one or more COVID-19 case, and 73% of assisted living have. But what sticks out to me is that nothing says battlefield or front lines more than this number right here. We've had 11 buildings that have had staff that have died from COVID-19. And there's nothing more difficult for a worker than getting up, going in every day, trying to fight off this horrendous disease and protect residents and other staff while watching one of their colleagues lose the battle against this very disease. In addition to the challenges of workers going to work and dealing every day with pandemic and related issues, that we know that they're also challenged by the fact that they are having to do more with less. We have had chronic workforce shortages in direct care in long-term care as well as medical for quite some time. I have a whole nother presentation as part of this series on that. I encourage you to take a look at it. But COVID-19 has accelerated that. Quarantines, child care issues, remote schooling, and even more concerning is that we have seen the numbers coming through the pipeline of education to move into these fields and take up these jobs has declined. Some of that's due to delays in training, testing, certification, but some of that's due to fear. Another thing that I've learned is that in addition to the direct care staffing shortages that we're facing, we are also facing shortages in other types of staff. And so what I've learned is that we have shortages in housekeeping, dining services, activities, infection preventionists, and other support staff for assisted living and skilled nursing as well. One of the key areas for workforce shortages when it comes to skilled nursing and assisted living is in the area of certified nursing assistants. These are employers of over half of all CNAs throughout the state of Washington. And what we've seen is that we've had state closures of exam sites, a phased reinstatement of exams, slower testing with COVID-19 precautions. What we've seen is we've seen a drop in the number of individuals who are actually certified as a nursing assistant and an increase in the number of those waiting to be certified. And by law, you are allowed a certain window of time in which to, when you finish your training, to actually take your exam and become certified. And so the Department of Health is reporting a backlog of 4,300 individuals or more that are waiting to get certified. And if they don't get certified within a certain window of time, then they lose their ability to be paid workers. So some policy is being worked on as we speak that will allow these workers to continue to work in this field while they're waiting for the backlog to get caught up. In addition, we have some slower testing that's taking place. The first-time testers are dropping significantly, and I believe some of this is due to fear. This is not a high-paid working field. It's 15 to maybe 17 or $18 an hour. And so when you're talking about walking into a situation that is potentially COVID-19 positive and you're getting $15 to $17 an hour, I think that it is causing some reservations for individuals who might otherwise choose these fields. This just takes a look at certified nursing assistants combined with those waiting to be certified. And what we see is that over the past few years that this has been on a decline, and it's accelerated with COVID-19. And so as employers, skilled nursing facilities and assisted living employ over half of all certified nursing assistants in the state. So as we move forward in policy, one of the questions is, what is the aftermath going to be from COVID-19 on this workforce? Again, it's low paid workforce and it's very hard work. And here's where I think it's really important to talk about providers are doing whatever they can, whatever it takes to make sure that the residents are getting the care that they need and that their staff are safe. And so one of the interesting data points that came out in this is that our face-to-face time between nurses and residents has actually increased with the COVID-19 pandemic. In fact, it's increased by 7.1%. And so what are providers doing? We know that some providers are paying for childcare, or groceries, or providing other assistance. And when it's allowed, some are using staff from other facilities. And I liken this to our substitute teaching system, where when the teachers can't show up for work that day, we have a call-in system where substitutes can go in and they can float from school to school to help fill the gaps and make sure that the appropriate teacher to student ratios are in effect. This is the same with skilled nursing facilities and assisted living. They do the same thing to make sure that the residents actually are getting the face-to-face time they need. They're also using contracted agency staff, which is coming at a high cost to them and to the system because Medicaid does not pay for agency staff, but they're doing what it takes to fill the gaps. And 78% of the providers are providing hero pay or bonus pay. And a number of providers as well are offering overtime and double shifts to make sure that the residents are getting the care that they need. And so I mentioned to you that providers are using agency staff to try to help fill the gaps and make sure residents are getting appropriate face-to-face time. And one of the things that is coming at a severe cost to the system is that the agencies are also increasing the amount that they charge for as in crisis rates because they are also trying to offer hero pay and keep their nurses on the front line. So as we use agency staff, the costs are increasing, and this is one of the worst case scenario examples that's coming out of the Spokane area where we see the hourly rates paid for agency staff here in gray, and the January 2021 rates in orange. They have increased significantly. And once again, the concern here is that for any facility that's providing care to a Medicaid insured individual, Medicaid will not pay for the cost of this extra cost for agency contracted staff. We're also seeing some pretty big drops in the number of individuals in assisted living and skilled nursing facilities. We know that some of this is due to some local health jurisdictions putting holds on admissions. And it's also very understandable that individuals might choose not to go to one of these places because they won't be able to see their family. It impacts their ability to be with their loved ones or see anybody that they love or care about. And what we know, though, is for providers that this impacts their ability to make payroll. It also impacts their ability to pay for fixed costs because it does affect the amount of revenue that's coming through the door. For skilled nursing facilities, we've seen a drop in occupancy by as much as 10%. And we know that assisted living is receiving a drop in admissions as well, as fewer residents are seeking care in assisted living, as well as some residents are choosing to move out. The next thing I wanted to talk about was testing. We've had about 163,000 point of care tests happening in skilled nursing facilities since September. And we've seen that this has been sort of a slow ramp up as we were getting the tests out and getting them distributed. But now it looks like it's pretty steady here in January, with the last data point being January 17th on this slide. Where we're running into challenges with testing is in the area of regulations and costs. We know that local health jurisdictions are setting the frequency for testing as well as regulations, and these vary from county to county. So in some counties, assisted living is the same as skilled nursing facilities. We're also getting routine guidance from CMS for skilled nursing facilities. There's 2 different types of tests that are being conducted, and the frequency by which these are being conducted varies. And we know that the compensation for COVID-19, just figuring out how to get it paid for is time-consuming and confusing. For example, residents, if there's an outbreak, sometimes it's paid by the local health jurisdiction, and if not, sometimes the resident's insurance will pay for it. If there's not an outbreak, if it's routine or prevention, then sometimes the resident's insurance will pay for it, but not always. With staff, if there's an outbreak, sometimes the local health jurisdiction pays for it, but often the provider themselves must pay for the testing. If it's routine testing, it's sometimes covered by the state lab and sometimes the local health jurisdiction. And also we have several instances where staff are utilizing their own health insurance to pay for testing. This slide gives you an example of the multiple sources that providers are chasing after to get testing paid for. And what we see is that with resident testing, providers are paying for the testing on residents at least 28% of the time, finding other sources to pay for it most of the rest of the time. With staff, we see that providers are paying for testing at least 26% of the time, and these other sources are being utilized to pay for it the rest of the time. The next thing I wanted to talk to you about was personal protective equipment, or PPE. What we know is 78% of providers are having a difficult time obtaining PPE because suppliers are limiting orders. We also know that 55% are reporting having difficult finding suppliers with the type of PPE they need. The data on this graph is from the CMS COVID-19 skilled nursing facility data set. And what this is telling us is that we still have skilled nursing facilities that are struggling with a week or less of PPE on hand. So we can't talk about PPE without talking about costs. The PPE costs have increased as much as 386% with the onset of COVID. And believe it or not, some of this is explainable. We've got a higher burn rate, so our providers are actually using more PPE than they ever have. But they're also competing with the general public, who are also using PPE. So the demand is way up. But the supply is way down because we have manufacturing shortages due to raw supply shortages. We have the inability to produce fast enough. We have challenges with distribution chain, and we have reduced production in some cases because the manufacturers themselves have been experiencing COVID-19 outbreaks. And so here's the example of the PPE costs coming by way of some suppliers. We can see that the average cost in January is these orange blocks, and the red blocks represent the average costs in January of 2021. So significant increases specifically related to COVID-19. In summary, I think it's important to point out that most providers, if not all providers, are doing whatever it takes to keep their staff and the residents safe, regardless of the cost or funding resources. And while I don't want to just solely talk about the bottom line for any of these providers, I think we have to at least acknowledge that skilled nursing facilities have been on a negative operating margin for a few years now before COVID-19. So we're at a critical point when it comes to the ability to make payroll in skilled nursing facilities. I think the biggest thing that I'm struck by is when I look at the costs, it's not just money, it's physical and emotional as well. And so I have a few quotes here from the Sentinel Network where staff are reporting, despite lower census, staff members are doing more. And it impacts different occupations differently. Frontline staff are having to be everything for every resident without their families. And that includes comforting the grandmother who is missing out of the birth of her first great-grandchild, to picking up and delivering packages from the front door because we're trying to keep the traffic down in communal areas, to offering normal day-to-day nursing services. The staff is working very hard. They're working under staffing shortages in a very, very critical time. They are our front line. In addition, they're dealing with their children at home and remote schooling, and sometimes being quarantined themselves for the pandemic, and the fear of taking care of their family and not bringing home a horrendous disease. So I think that what sticks out to me in all of this is that we need to have some grace for each other. It's not about blaming any particular entity, government, providers, whomever. It's more about what can we do to set policies that protect our residents, but also provide grace and help to the providers who are doing what it takes to actually make sure that residents and staff are safe. If you have any questions or would like more information about the data or technical material in this presentation, please feel free to reach out to me. If you would like information about advocacy or the policy recommendations included in this presentation, please contact Washington Healthcare Association and/or Leading Age Washington. All of the resources that were used to build the data analysis in this presentation are available to you upon downloading this slide deck. Thank you.